Hey everyone, welcome to my YouTube channel, Just Another Medic. In this video we're talking about type 1 and type 2 diabetes. We'll be starting by discussing the physiology of how blood sugars are maintained, comparing type 1 and type 2 diabetes, the symptoms that diabetic patients present with, how you investigate it, and the complications that diabetics suffer from. This video won't be covering the management of diabetes. To find out more on how you manage diabetes, look out for my other video on this channel. Let's start with the basic physiology of how glucose is maintained. Glucose is under control of two hormones, insulin and glucagon, both produced by the pancreas in the islet cell of Langerhans, glucagon produced by the alpha cells and insulin produced by the beta cells. When someone eats something, their blood glucose level rises, and with that the pancreas releases more insulin. Upon release of insulin, more glucose is taken up by cells, protein synthesis increases, and the glucose is converted into triglycerides, which is stored for periods of starvation. Gluconeogenesis decreases, and glucagon, which is a counter hormone for insulin, decreases itself. In periods of starvation, glucagon is released and does the exact opposite of what insulin does. Increases glucose levels by promoting glycolysis, increasing gluconeogenesis, and lipolysis. In type 1 diabetes, this whole process is destroyed by autoantibodies, which release and target the beta cells of the pancreas, preventing the production of insulin. In comparison to type 2 diabetes, where insulin is still produced and released by beta cells, however, the target receptors for insulin are insensitive, producing a lack of response. Type 1 diabetics tend to be younger and thinner, whereas in type 2 diabetes, the patients tend to be of an older population and tend to be obese. Obesity is part of the pathophysiology causing type 2 diabetes. Very high levels of glucose can cause acute complications in type 1 and type 2 diabetics. In type 1 diabetes, you get something called diabetic ketoacidosis, where you've got a high glucose plus metabolic acidosis. In type 2 diabetes, you get something called hyperosmolar hyperglycemic state, where there's a high level of glucose but there's no metabolic acidosis. To learn more about diabetic ketoacidosis and hyperosmolar hyperglycemic state, otherwise known as HHS, look out for my video on this channel, where I compare both the conditions and run through its management. As mentioned before, type 1 diabetes is affected by autoantibodies. Therefore, you can find antibodies such as GAD65, islet cell antibodies, insulin antibodies positive in type 1 diabetes, but you can't find any autoantibodies positive in type 2 diabetes. Type 2 diabetics tend to have a positive family history and have a higher concordance within twins. Type 1 diabetes has HLA associations, such as with HLA-DQ, DR3, DR4. Overall, type 2 diabetes is more common than type 1, with 90% of diabetics suffering from type 2 diabetes. To learn about the symptoms of diabetes, you need to remember the triad of polyphagia, polydipsia, and polyuria. As these patients are unable to utilize the glucose within their bloodstreams, they start to use up resources stored within their bodies, causing a loss of weight. In turn, this leads to other symptoms such as anorexia and lethargy. It would be great if all our diabetic patients initially present with a triad of polyuria, polydipsia, polyphagia. However, that's not the case. Some diabetics' initial presentation is with diabetic ketoacidosis. Therefore, it's extremely important that you are able to recognize the symptoms of diabetic ketoacidosis, which can later on lead to the diagnosis of diabetes. These aren't the only symptoms of diabetes. Diabetes has various complications, and these complications produce symptoms which might be the only presentation of diabetes that the patient might have. So it's extremely important that you recognize these complications of diabetes. One method by which you can screen for diabetes is a urine dipstick test. Now, glucose is reabsorbed within the nephrons, therefore you should have none of it within your urine. However, if you do find glucose to be positive within a urine dipstick test, that should warrant further investigation for diabetes. You could do this by testing someone's blood. You can either do a finger prick test, where if someone's been fasting, their plasma glucose should be below 7. However, if you're just doing it randomly, it should be below 11.1. The other blood test that you could run is HbA1c, where you're checking for what proportion of red blood cells are glycosylated. If the HbA1c comes back above 6.5% or 48 millimoles per litre, then this is a diagnosis of diabetes. So let's run through these complications that diabetics suffer from. We can divide these complications as acute and chronic. We briefly touched on the acute complications such as DKA, HHS. Chronic complications can be divided further into 4 categories of its own: microvascular, macrovascular, autonomic neuropathy, and dermatological. Microvascular complications include retinopathy, nephropathy, neuropathy. Neuropathy presents as a glove and stocking distribution, reducing the sensation within your hands and feet. Macrovascular complications are due to atherosclerosis, causing coronary artery disease, peripheral vascular disease, and stroke. Autonomic neuropathy is where there's damage to the nerves within the autonomic nervous system, causing symptoms such as increase in resting heart rate, orthostatic hypotension, gastroparesis, and erectile dysfunction. Acanthosis nigricans is one of the dermatological complications, which is due to excessive insolation, causing darkening and thickening of the skin. Other dermatological complications include necrobiosis lipoidica. Thank you very much for watching this video. I hope you learned something new. To find out more about diabetes, check out my other videos on this channel.